Toronto and here in the Research Institute at CHES, with a major focus on child health equity research. We have, as part of our team, incredible researchers, research staff and trainees, and together with my colleague, Astrid Gutman, have tried to build a bit of a community here of other researchers, policymakers, and other knowledge users who work together with us and with our communities that we are privileged to partner with in improving the flourishing and health outcomes of all children. We have two previous research chairs who have been recruited as kind of the spine of our center. Dr. Catherine Birkin was the inaugural Leong Chair in interventions, and Dr. Arjun Siddiqui was the inaugural Leong Chair in policy and child policy. And we're so excited today to introduce Dr. Aasthaa Bansal, who has come to us is a partnered recruitment. She's going to work both here in our Research Institute and also in IHPME and the Daulana School of Public Health. And I want to especially call out thank you to Steny Brown, the Dean at Daulana, and Audrey Laporte, who's been leading IHPME, who have really worked really diligently with us in a partnership, not just for bringing Dr. Bansal to Toronto, but for other really important intersections between the work we do in our center and the amazing work that goes on in the School of Public Health. So to introduce our speaker today, Dr. Bansal, I learned began her career as an undergraduate student at the University of Waterloo and actually did an internship here at CHES as part of that, and then went on and completed her PhD and a postdoctoral time at the University of Washington, and comes back to Toronto where she will be the inaugural Edwin S.H. Leong Chair in Data Science for Child Health Equity. She has incredible experience in prediction modeling, in comparative effective research, and in how we handle missing longitudinal data, really important areas of research, and really thinking deeply and richly about how we can incorporate data science into the work that we do. You know, we were joking before about what our kids will do when they grow up, and I can say the hardest recruitment sometimes for research institutes nowadays and for universities and university departments is recruiting data scientists, that and I guess influencers. So we're particularly privileged that Dr. Bansal came to accept this position, and we're so excited for everything she will do with the center, with the school, and with hopefully many of the people in the room. So welcome, Dr. Bansal.
Thanks, Al. Can you all hear me? Okay, yeah, great. And thank you so much for having me. I'm excited to be here. My goal today is to kind of give you an overview of my work. So I put child in parentheses in the title of my talk because this is more about methods that have been applied and could be applied more generally to a range of disease areas. A lot of my work so far has been in the adult population, but I'll talk about, you know, how I'm sort of thinking about extending that to child health and hoping to foster collaborations through this presentation with you all. So just to begin, and Al already gave kind of my background, so I had this timeline. Wanted to call out that, yes, I am Canadian. I went to the University of Waterloo many years ago. I moved out to Seattle, did my PhD and postdoc in Biostatistics in the University of Washington, and then was a faculty member for 12 years at the Comparative Health Outcomes Policy and Economics Institute in the School of Pharmacy there. And I had a joint appointment with Fred Hutch Cancer Center. And I'm proud of this journey. I spent almost 2 decades in Seattle, and I'm excited for the work that I did there and to now have the opportunity to bring it here to the Leong Center. just sort of to give you a very high level overview of my research, it's a kind of a combination of traditional and contemporary methods, just your standard regression models, survival analysis, and then more getting into machine learning in the last 5 years or so. Different types of data sets, randomized trial data, but mostly observational data sets, EHR claims, registry data. I work a lot with longitudinal data sets, as you'll see in my presentation, and a variety of application areas. And so these are sort of the 4 themes of my work, and I'll touch on the first 3, which are precision population health, sort of leveraging longitudinal health data, and machine learning to inform sequential or dynamic decision making and reduce low-value care. I'll talk a little bit about statistical methods that we've developed and are working on to address health equity and other challenges that we've run into while trying to use real-world data to do health research. And I'll finally touch on some health services, health outcomes types research that I have conducted leveraging different linked data sets. So starting with the first topic of precision health, so we're familiar with the Choosing Wisely initiative and the Choosing Wisely Canada arm of it that talks about how surveillance and treatment that's routinely used in clinical practice needs to be thought out a little bit better. So, it's common in many disease areas to monitor patients on a regular basis, and the guidelines are typically sort of one size fits all for all patients, but you have lower risk patients who may not need to undergo the cost and inconvenience of frequent tests. And there's harms of over-testing, over-treatment, and that's kind of what prompted a lot of our work in this area of personalized risk adaptive surveillance, or PRAISE as we call it. So this was done under a grant from the National Cancer Institute of the NIH, and the general idea here was that if we can accurately predict risk of recurrence, this was based in cancer, if we can accurately predict risk of recurrence among patients, perhaps we could allow for low-risk patients to undergo less frequent monitoring and high-risk patients to be targeted for more frequent monitoring and potentially early intervention. Right? So the goal here is to optimize the timing of surveillance testing. And this is supposed to be somewhat informal and a chat. If you want to interrupt me at any point, ask a question, just raise your hand. I'm happy to be interrupted. So the general idea here, like I mentioned, is clinical guidelines are often sort of one-size-fits-all strategies, and in many disease areas, the idea is you monitor patients every 3 to 6 months. The assessment of whether it's 3 months or 6 months can be a little bit subjective based on physician understanding of the disease state of the patient. And you monitor frequently, and I'm going to try to use this mouse here. And then, on the x-axis here, I have time in months, and on the y-axis, I have some tumor biomarker measurement or any biomarker measurement. At some point, if it starts to go over some predetermined risk threshold, then that prompts intervention, further diagnostic workup, and treatment. And what we are sort of hypothesizing is that we could use a patient's accumulated information, their disease trajectory, their biomarker trajectory, to try to predict where they may be in, say, 3 months from now, 6 months from now, and allow them to undergo less frequent monitoring based on that prediction, right? So in this toy example, this patient came in at 9 months. Based on their trajectory so far, we predict that in 6 months from today, they will still be low under that risk threshold, and so perhaps they can skip the next visit. Now, what's an issue with predictions? It's that they're uncertain, right? We don't really know where the patient will be 3 months from now or 6 months from now. We can't predict the future. We can predict it pretty well in many cases, but not perfectly. And so the idea or the question that we ask is, okay, if this patient did come in at 12 months, if they didn't skip the next visit, what's the probability that testing at that time would change their treatment decision? Would we actually treat them if they came in at 12 months? And if we did, then what's the consequence of that treatment or that action on their outcomes? And so that idea is summarized by this concept from statistical and economic decision theory called value of information, which asks exactly those two questions. It asks, what's the clinical utility of additional information? How likely is it to change our decisions, and what would be the consequences of that change? And so we applied this idea to patient individual decision making on a dynamic basis through this decision problem. And so we're saying, okay, a patient has come in today. We call that time T. Based on their information today, we make a decision of whether we should treat them or not treat them, right? If they're looking okay, if they're looking disease-free, progression-free, we decide to not treat them. And if we don't treat them, now the decision is about when they should come in next. And should they come in next for their test and therefore the opportunity to be treated at time t+1, which is what we're calling the next time point after time t, or should we not test at t+1, which means that they also don't get the opportunity to be treated at t+1, right? We're just saying you skip your visit at t+1. Now, if they come in at t+1, we're faced with the exact same decision. We collect their information at time t+1. We again say, okay, now based on their updated status, do we treat or do not treat? If we don't treat, then again, when do we test next? Do we test now at t+2, which is the next time point, or do we skip the t+2 visit and come in at the following time point? And same thing if we had gone down this lower route where we said don't test at t+1, they would have then come in at t+2, and we would have asked the same question, like based on your information today, do we treat or not treat? If we don't treat, do we test at t+3, or do we skip the t+3 visit? So you get the idea. Basically, every time the patient comes into the clinic, we're asking the same decision or same questions, and therefore it's the same decision problem that we're solving at each time point. And so we kind of quantified this using this decision-making criterion that we call the expected value of information from surveillance testing, or EVIST. And so at time t, we calculate the expected utility of testing at t+1, and also the expected utility of not testing at t+1. Right? We take the difference, and if the expected utility of testing at t+1 is higher, then we would have the patient come in at t+1. It's the way that we've quantified it is in life years. So we say we predict how long we expect this patient to live if they did come in for their testing at t+1 versus how long do we expect them to live if they didn't come in at t+1. And if that difference is positive, if it's greater than 0, then we would say, okay, come in at t+1. And then that criterion could be monetized if you're trying to look at costs of testing. You would say, okay, well, we monetize the life years in the EVIS criterion using some threshold, say like $100,000 per life year, which is sort of standard that health economists try to use. And for that monetized EVIS value, we would then compare it to some cost of testing. And so that's saying, okay, this is your benefit from testing versus here's the cost of testing. And that cost could include the actual cost of the test. It could include the cost of taking time away from work. You can include different costs in just to combine into the overall cost of a visit. And so again, if the monetized EVIS is greater than the cost, then you would recommend the patient come in. And so just to put that together, the idea here is that we obtain first dynamic predictions at every time point that the patient comes in. We use their information up until that time point, predict their either future biomarker value or their risk of some adverse event that you're interested in, and then embed those predictions into a sequential decision-making framework that allows us to maximize the decision at that time point. And so we applied this to a cystic fibrosis data set. So at the time for analysis, the guidelines recommended measuring FEV1, which is a standard measure of pulmonary function, every 3 months for all patients. And referring to lung transplant if the FEV value at a given visit was lower than 40%. We contrasted this sort of what we call the always test strategy with using a risk adaptive strategy and seeing if it allowed for less frequent FEV measurements for low risk patients. And it was based on data from the US Cystic Fibrosis Foundation patient registry. And the general result was that the risk adaptive strategy did indeed lower costs compared to an always test strategy by allowing patients who had better lung function to skip a visit. And so the less frequent testing was only recommended to patients who were unlikely to be treated at the time point they were skipping. So we don't want to be lowering costs at the expense of worse health outcomes. And that is what we were able to achieve by accurately predicting who those low-risk patients were who were unlikely to be referred for lung transplant at the visit that they were skipping. And so this plot on the left shows patients who had lower baseline lung function tended to have, on average, higher value of testing versus those who had higher baseline lung function tended to have higher value from testing. And so that this paper was published in 2022, 3 years ago, and for the past 3 years, we've been applying this idea to a more complicated setting of colorectal cancer recurrence, where the general idea is that, once patients are diagnosed, they undergo primary treatment, and then after some period of 3 months when their biomarker value is allowed to normalize, then start surveillance for recurrence. And for stage 2 and 3 patients, the guidelines say that patients should undergo surveillance testing using the CA biomarker every 3 to 6 months. And so again, our goal here was to predict the dynamic risk of colorectal cancer recurrence using the most up-to-date information at a given patient visit and use that to personalize surveillance. Existing risk prediction models in the space use only baseline information and tended to have AUCs, or area under the ROC curve, that was fairly low, like between 0.6 to 0.72. And however, clinical practice does use CEA biomarker trends. Clinicians know to look at the trend in the biomarker to make decisions, but that's not really incorporated in the guidelines or in existing risk prediction models. And so that's kind of what our goal was, to try to incorporate that longitudinal biomarker information in a more systematic way to help decision making. And so just this picture shows, up until a given time point T, we're using the biomarker information up until that point to predict risk at time T plus 1 and T plus 2. And we used a number of machine learning models to try to fit all the patient data that we had. And if you're familiar with these models, you know that they kind of range from being interpretable versus flexible. Typically with the more flexible a machine learning model is, the less interpretable it tends to get. But there are some variable importance measures that can allow you to help make machine learning models more interpretable, and that's what we looked at as well. And so we use those models, again, to determine dynamic risk predictions. The idea being that every time a patient came into the clinic, we used their most up-to-date information to update their risk of recurrence in the next year. And this plot shows the time-varying area under the ROC curve. So ROC curve, which kind of captures, is a traditional conventional tool for capturing the model performance of, or the predictive performance of a model, ranges between 0.5 to 1. And here we summarize the area under the ROC curve for over time. So from baseline up until 55 months or so, we looked at the performance of the different models that we fit, and we the highest performing model had an AUC of ranging from 0.5 to 0.9. So, this is much better than what the existing models had been able to achieve, which was, AUCs of 0.6 to 0.7 or so. And this work was led by my former PhD student, Tricia. And the nice thing was that there's this thinking that a lot of machine learning models, again, are black box models that are hard to interpret. And here what we uncovered was that the best performing model just had a single covariate in it. It was simply the 6-month change in log CEA. So the prior 6-month change in the value of the biomarker or logged biomarker. And the nice thing about the machine learning method that we used was that it was able to identify a nonlinear relationship between the biomarker and risk of recurrence. What I mean by that is it was able to help give us this sort of guide that says, okay, if in the last 6 months there's no increase in the log CEA, then that translates to a nearly zero risk of recurrence in the next year. And if the increase is more than 0.4, then that translates to a risk of about 44% in the next year. But anywhere in between, then that depends on the value of the change. Any questions so far? All right. And so again, we developed this dynamic risk prediction model and we embedded into this decision-making problem where we sort of adapted that earlier decision-making framework to this specific setting of colorectal cancer recurrence, where again, we're saying, okay, at time T, after we made the decision to not treat, we're trying to decide whether the patient should come in for a test at T+1 or T+2. If they come in at T+1, we get to observe recurrence or no recurrence and treat accordingly. But if they don't come in at T+1, they may still be underlying progression. There may be recurrence that then continues to be local recurrence. So there may be local recurrence that continues to be local recurrence at T+2. There may be an observed local recurrence that progresses into no longer local or metastasis, which then we have now identified late as a result of having the patient skip the visit. You may have metastasis at T+1 that has now progressed further at T+2. And so it's what we're trying to reduce is the risk of missing these recurrences by saying, okay, if there's patients are at high risk of recurrence, then they should be coming in at T+1. And also quantifying, okay, if they did miss the visit, then what is sort of the cost or the difference in outcomes of being treated later, so 3 months later, if they did skip that visit. And so this is sort of ongoing work, and we're completing a microsimulation model where we're comparing this risk adaptive surveillance strategy to guideline-based surveillance in terms of the outcomes, so health outcomes, whether we're missing recurrences, if we're keeping survival the same between the two strategies while minimizing costs. And this is part of a huge collaboration. What I talked about was work in colorectal cancer. We kind of are applying different flavors of the same idea in chronic myeloid leukemia and also in prostate cancer, and working with health economists, biostatisticians, and trainees. And this project's actually wrapping up now. It was a 7-year project that just is in the no-cost extension phase now. And I've been excited to have the opportunity to apply some of these ideas with folks here at CHES, with Petros Peklivanoglu and Princess Margaret, with David Hutchinson, to try to optimize cardiac screening in survivors of childhood cancer. Just again, the idea here is that survivors of childhood cancer who are being screened with echocardiograms for heart failure, can we do better than what the guidelines suggest and come up with some dynamic risk predictions and improve upon guidelines in terms of cost effectiveness. In other ongoing work, I'm also trying to extend this framework for decision making beyond just looking at risk. So what we've so far done and what is common practice is to use a bunch of patient covariates throw them into a model and get some predicted outcome without treatment, which is what risk is, right? So it's the risk of some adverse event without treatment. But can we also then predict outcomes with treatment? And so this gets into causal inference. And what we're trying to look at is individualized predictions with treatment minus predictions without treatment, and identify patients who would have a net gain in outcomes if they did get treatment. So not just identify high risk individuals, but identify high risk and high benefit patients. So that's kind of the precision population health theme of my work. And then while doing this work, we actually ran into some issues which prompted the development of statistical methods to address biases that we saw as a result of this being data that's collected from regular real world clinical practice. So the data that we used for this research was from Kaiser Permanente, Southern California, which is a huge linkage of registry data, lab, healthcare services, pharmacy claims, and patient and provider demographics, as well as geocoded data. And so it's a great, rich source of data, but the issue we ran into was from infrequent patient visits. So like I said before, guidelines recommend that patients come in every 3 to 6 months, which translates to 2 to 4 tests a year. What we found was, on average, patients were coming in about 1.2 times a year, right? So you see patients, for example, in this plot, I have patient IDs of 20 random patients on the y-axis and time on the x-axis, and like patient 7 came in once in 12 months, and then twice in the following 12 months. Patient 6 came in once in the first 12 months, once in the following 12 months. And then there are patients who come in often. So there's heterogeneity in how frequently patients come in practice. Now, issues that can arise, some of the issues that can arise due to intermittent or infrequent patient visits is, first of all, you'll have missingness in lab measurements, right? So if we're trying to capture these biomarker values on a regular basis, if patients are coming in once a year, that's how often we're capturing their lab measurements. And the typical approach is to say, okay, if I'm trying to do analysis with longitudinal data and I have a patient who had like 1 measurement, I might just exclude that patient because I was expecting 2 to 4 measurements. We also have delayed outcome ascertainment because we have something called interval censoring that's happening, right? So if a patient came in at 3 months and then the next time they came in was 12 months, we are able to capture their events at 3 months or 12 months, and what's happening in between, we're not really capturing. And so that, in the case of recurrence and many other diseases where we're trying to capture progression of disease, you're not only missing the timing of progression, but also the severity that's being recorded might be a higher severity by the time the patient comes in. And so now, if we're trying to do analyses where we're separating high risk versus low risk patients, you can imagine that the patients who came in less frequently had their outcomes measured later, and they appear erroneously to look like low risk patients, whereas they may actually have experienced the outcome, we just didn't observe it. Right? And what we found was these issues were systematically worse for disadvantaged populations. So in our case, we looked at racial and ethnic minorities, and we found, first, in terms of biomarker testing, we found that Black and African-American patients tended to have significantly lower surveillance testing in the first year of surveillance compared to non-Hispanic white patients. And that was after adjusting for a bunch of clinical covariates. And then in terms of outcome ascertainment, so just talking a little bit more about how we actually captured outcomes in our data set. So with cancer recurrence and other events, they're not readily available in structured data. So there's not a field in claims or EHR data that said this patient experienced recurrence. The gold standard is to do chart review and try to gather that information, extract it from patient charts. But when you're dealing with thousands or millions of patients, that's a very labor-intensive, expensive task. And so it's been common practice to sort of look at healthcare utilization patterns to try to get at proxies of those outcomes. And so there was an existing algorithm when we were doing this analysis that we adapted to our data set. And it was a rule-based algorithm that said, okay, if this patient had surgery for recurrence, then we said, okay, this was a recurrence. If they had chemotherapy that would be given for metastasis, or if they had imaging that was accompanied by a diagnosis code for metastasis, or if they had hospice accompanied by a diagnosis code for metastasis, those were the 4 sort of events that would prompt us to record this as a recurrence. Now, based on what I've talked about, you can see a potential issue with this approach is that it requires a patient to have come into the clinic and have received these healthcare services, right? Either been treated for their recurrence or have undergone imaging or hospice. And so we dug into this further, and we found that, yes, the healthcare utilization varies across subgroups, and that these utilization-based proxy outcomes are more inaccurate among disadvantaged groups. And so you can, again, like I said, imagine if you are mischaracterizing outcomes, if you are, for patients who are not able to come into the clinic as frequently as other patients, maybe they have like jobs that don't allow them to take time off, they have other responsibilities. Now, we are systematically kind of labeling them as low-risk patients or patients who didn't experience the outcomes or experience them later than other patients because they just didn't come in until later. And then if you're doing predictions, that's problematic, like I discussed. If you're looking at treatment effects, you will also inaccurately quantify the effect of certain treatments on these patients because you may say, okay, this treatment doesn't look like it was beneficial for this patient. They didn't have the events, or maybe it was more beneficial than it actually was, right? And so we can end up misdirecting resources and making inappropriate healthcare decisions. In our case, we actually interestingly found that Hispanic patients had a higher false positive rate of recurrence. We had expected it to be a false negative rate and that we were missing recurrences. And what we found was there was a higher false positive rate because the way that we started the window of surveillance was, okay, you had your primary treatment, then you were allowed 3 months for your levels to normalize, and then starts your surveillance window. And so this was kind of artificially created by us because there's nothing in the data set that says this was the start of surveillance. But what we were picking up as recurrence using our algorithm, like I showed, like using these 4 measures of healthcare utilization, we were actually picking up primary treatment that was delayed and going into the window that we were designating as surveillance. And so it can really go either way, that inaccuracy. And so the question we asked was, can we make data collection and analysis more inclusive and less biased? And so the risk prediction model that we developed, the dynamic risk prediction model that I presented results for, we actually did a whole bunch of data pre-processing before we did that analysis to try to get it right. And our general approach was to try to use data on patients who had more complete information to impute data for those who had less complete or maybe delayed outcome ascertainment. And so we call this a principal statistical approach to pre-processing data. And basically, there were 3 steps. The first step was to impute, in this case, our outcome was recurrence time and severity. The second step was then to impute the longitudinal biomarker trajectory and then use that imputed data set to fit and evaluate our risk prediction model. But that analysis could be anything. It could be an estimation of a treatment effect as well. And so just to give you a very high level overview of what we did was to impute that outcome. We modeled the natural history of recurrence using a multi-state Markov model, where we said, okay, patients start with no detectable recurrence. They may progress to resectable liver or lung metastases, which may then progress to no longer resectable liver or lung metastases, and followed by death. They may go from no detectable recurrence to never resectable metastases, so metastases to the bone or the brain, which are never resectable, and then proceed to death, or just go from no recurrence to death. This model was fit using our patient level EHR data, and we used it to then impute recurrence trajectories for patients who we had observed recurrence for. So what I mean by that is I have two examples here of patients. So this patient, the black diamonds represent what we observed. And so up until about month 8 or so, we observed that they had no recurrence. And then in month 13 or so, or 13 and a half, we observed that they had never resectable recurrence. And so they could have progressed to that recurrence during that 8 and 13 month mark. And so we kind of imputed these 10 realizations of the recurrence trajectories because there's uncertainty in when that would have happened. And it turned out, so it could have been that they progressed at 9 months. So we imputed, in 3-month intervals. So it could have happened at 9 months and we would have observed it if they had come in at 9 months, or it could have happened at 12 months and we would have observed it then, or it really happened exactly when we observed it. And so it ended up being like 3 unique trajectories, and those are weighted by how often they occurred in the 10 realizations or 10 imputations we did. And for this patient on the right, they were observed up until about 12 months with no recurrence, and then, at about month 16 with no longer resectable liver or lung metastases. And so they progressed from no recurrence to resectable to no longer resectable during that time span. And we, again, imputed their trajectories and used those like 10 realizations of their recurrence trajectory in our analysis. And then the next step was using those imputed recurrence times to impute longitudinal biomarker trajectories. And I'm going to summarize a ton of work in one slide that my amazing students did, which was to these are 10 random patients and their biomarkers log CA trajectories across time. And you see that, some patients have like just one visit, one lab measurement at baseline, and then another one at like 4 years. And so through this process of imputation, where we fit a model that included patient and physician characteristics that might predict missingness, as well as patient disease characteristics that might predict the value of the biomarker, as well as the time of recurrence, we were able to impute these biomarker trajectories for each of the recurrence times that we had imputed. So basically, we had 10 different recurrence times, and then for each of those 10, we imputed a biomarker trajectory and used those 10 realizations in our analysis. So that was the process, and then that gave us this analysis, this imputed data set that we then were able to do our analysis and allow for more equitable and inclusive data collection and analysis to minimize bias. All right, and so that kind of covers the first 2 major themes of my work, and then I'm going to touch on 4 different projects in 10 minutes. So just going to give you a kind of a breadth of the work that we've done in this space of health services, health outcomes research using data linkages. And so the first one is racial disparities in clinical trials or access to clinical trials. And the background here is that it's known that Black and African American men tend to experience a higher incidence of prostate cancer. And the question we asked was, do they also experience disparities in access to prostate cancer clinical trials? And so we conducted this linkage with clinical trial data in prostate cancer from clinicaltrials.gov and linked it to, we gathered county level data. So the counties where these prostate cancer trials were occurring, and linked it to a database that gave us information, county level information on healthcare, hospitals and physicians, and so healthcare facility data for those counties. And using that linkage, we did this county level analysis where we investigated the relationship between the proportion of African Americans in a county and access to cancer facilities. And then among counties that did have access to facilities, the association with the proportion of African Americans with number of clinical trials per year. And we found in both cases there were disparities. And so counties with higher proportions of African Americans were less likely to have cancer care facilities. And among those that did have cancer care facilities, the counties with higher proportions had fewer prostate cancer clinical trials per year. And this was an analysis that was published in JNCI and done with collaborators at the Fred Hutch Cancer Center in UW. And there's been similar work that's been done just to kind of, again, show connections to all of this work to the pediatric population. There's been similar analyses and studies that have been done to look at disparities in access to clinical trials in pediatrics. One of them, the bottom study was actually led by Lillian Sung here at CHES, and they used the Cancer in Young People in Canada database and found that non-enrollment of in clinical trials was associated with a lack of available trials, physician choice, Asian and Arab or West Asian race. Another study that we did, and I like to call this out because this is my most cited study, and it was in the space of financial toxicity in cancer. And if you're familiar with the term financial toxicity, or rather if you're not, then it's the financial hardships that patients face due to high out-of-pocket costs or high out-of-pocket spending in cancer treatment. And this is a big problem in the US especially. And we set out to answer the question of looking at the relationship between severe financial distress captured using bankruptcy filing and mortality risk among cancer patients. And we, for this analysis, linked cancer registry records from Western Washington with federal bankruptcy records. We were able to identify over 230,000 patients who were diagnosed with cancer between 1995 and 2009, and 4,700 that filed for bankruptcy. And now we wanted to compare between those cancer patients who filed for bankruptcy versus those who didn't in terms of their survival. You can imagine that patients who file for bankruptcy versus those who don't are probably different in more ways than just their bankruptcy filing. And we found that, bankruptcy filers tended to be patients who were actually treated, younger at diagnosis, female, had local or regional disease versus distant or metastasized. They're lower income and non-white patients. And so to be able to do a more fair comparison of patients who were more similar to the bankruptcy filers, we conducted a propensity score matching. And in that sample, then we did a survival analysis for the Cox regression with bankruptcy filing as a time-varying exposure and time to death as our outcome. And we did find that indeed patients who filed for bankruptcy were at higher risk of death. The mechanism by which we hypothesized in that paper that these poor outcomes might be occurring would be due to inadherence to treatment. So after a patient files for bankruptcy, they're probably, or even before that, as they're experiencing more financial strain, they may start not adhering to their chemo, for example, and therefore end up having poorer outcomes. There's also the stress, but we then went on to focus on adherence. And so in some other work, I looked at disparities in medication adherence in patients diagnosed with chronic myeloid leukemia. We used claims data and pharmacy claims data to calculate adherence in 30-day intervals. So the common practice is to sort of look at adherence in large chunks of time, like look at 1 year adherence, for example, and we looked in 30-day intervals in a longitudinal fashion and using a latent profile analysis, and we kind of came up with these trends in adherence. And our interest was in patients who were stably adherent, so basically stayed over 80% adherence for 1 year, versus those who started of being adherent and then became non-adherent, so fell below that 80% adherence threshold, which is kind of used as a common threshold of being adherent. And we found that those patients who did become non-adherent tended to be younger, female, have a higher monthly financial burden, and have fewer comorbidities, sorry. In a more recent study in medication adherence in CML, we also looked at sort of patient-physician concordance and how it associates with medication adherence. And one thing I didn't mention, in case you don't know, is with chronic myeloid leukemia, it's important to be on your oral chemotherapy. Sort of the guidelines are to be on it indefinitely, and to achieve good survival outcomes, you need to be adherent. And so that's why there's been a lot of work looking at non-adherence in this space. And what we found in this study was that patients who did not have concordance, so we looked at race, ethnicity, and gender concordance of patients with their physician, and no concordance compared to having gender concordance improved adherence in the 5-year span, and then having gender as well as race, ethnicity concordance improved adherence further. And so just, again, connecting this to work here, the work in characterizing longitudinal trajectories, similar work has been done by Dr. Catherine Birkin and her group in summarizing BMI trajectories in children. And so some very preliminary questions that we've been looking at or talking about are, how is healthcare access associated with growth patterns? And then there's also this amazingly rich resource of data that you all have at ICES, and had some very, very preliminary conversations with Astrid and Andy and Susitha about, addressing relevant questions in the child health space using this data set. And so I'm very excited about that. And I'm also excited about, again, just exploring how there might be biases that are built in here, given especially this health service visit data set, right? So it's the same thing where it's capturing individuals' interaction with the healthcare system, and what gets recorded depends on how often patients come into the clinic. And so in summary, hopefully I was able to give you a very high level, very quick overview of how we've used real world data to not only flexibly leverage longitudinal data to inform decision making, but also in creating novel data linkages and uncovering disparities in practice that might inform future interventions and policy, for example, to try to address non-adherence early on as it starts to occur. Like I mentioned, with all analyses we do using real world data, there's caution to be exercised. There's biases that are built into real world practice, and that can then get baked into real world data. And so appropriate statistical and data science methods that address these issues, for example, what we did imputing data, are important to think about and try to address. And that's it for me. Feel free to reach out if any of this appealed to you. I'd love to talk about how any of this work would apply to your research and build collaborations.
Great. Thank you very much for a great talk. It's sort of interesting. I was reflecting, when you work with population data and health service data, like, the bane of our existence is this tension between the ascertainment, and all, a health service record is both access and it's sort of clinical information. And,
Yes.
and I think as data are becoming more detailed and clinical data, everybody thinks that's going to sort of solve what I think is a more fundamental problem. So it's amazing to hear about methods that can start to, get at some of those biases. So thank you very, very much. We have a few minutes for questions before we then break, as Eyal mentioned, for some dessert and sort of more informal socializing. So anybody? Yes, over there.
Hi, a very interesting presentation. My name is Salima Kirai, and I am part of CHES, working as a postdoctoral fellow in Center of Global Child Health. It was very inspiring to see how you draw from different disciplines, biostatistics, and economic decision theories to apply those methods, theories, and principles to population health, especially adult health and child health. I just want to seek a couple of clarifications regarding the first precision population health project that you mentioned. I'm curious to understand, after how many patient visits the certainty of the prediction improves in terms of surveillance. And in one of the slides, you mentioned that this application of prediction to surveillance help us identify the low risk group and the high risk group. So again, asking out of curiosity, what proportion of the patient population is deemed as low risk group, and what proportion is the high risk group, generally speaking, based on your work on different patient population? And based on your third study on financial toxicity, I'm so curious again to ask you this question about when you looked at the profile of patients who actually were bankrupted and you found that they were treated. So when you did the propensity analysis in the subsequent study, did you do the post adjustment and heard about the treatment effects? Like, despite of receiving the treatment, they had poor outcomes and prognosis. So I'll stop at that and would love to learn more from you.
Sure. Yeah. Thanks for those questions. I'll try to remember them all. So I think the first question you're asking, like, at what point did you need, so how many measurements basically did you need to be able to make accurate predictions? And the way that we implemented this, we said the patients have to come in for their 3-month visit and their 6-month visit so that we have that to use in the predictions. And then that's how we trained the model. And that's how this decision-making framework would be applied in practice, where patients have to come in for their initial visits. And then from that point on, maybe you start personalizing it. And the model that I showed was trained on those 2 past visits. And just, as you saw, the 6-month change was accurate enough to be able to predict well. So, sorry?
At least 2 visits are needed, is it?
So it's starting with 2 visits. Now, there is this issue that, we're creating missing data, right? So by having patients skip visits, some patients will have only a visit that was 6 months ago, but not 3 months ago. And the goal is try to use the work that we did in imputing missing data to kind of apply in a more real world way or real time way to improve the predictions as well. So it's not truly missing data, we impute it and then use that for predicting. Sorry, I forget your second question.
What proportion is the low risk?
Oh, what proportion is low risk versus high risk? It depends on the disease setting. In colorectal cancer, highest, and I think in many cancers, your highest risk of recurrence is in the first 2 years. So 40% of patients can recur in the first 2 years. And then after that, the risk goes down over time. So the risk, high versus low risk proportions are kind of time dependent. They change. And then your last question was about the financial toxicity data set. And yeah, so did getting treated improve outcomes? So first of all, this analysis was done 10 years ago. So the details of like what exploration we did, I don't remember. But we did find that patients were at higher risk of filing for bankruptcy if they were treated because it's a cost. And then that went on to have them have poor outcomes. I don't think we looked at separate treatments. Like, so surgery would be, a one-time treatment versus if you had to have ongoing chemo, that's something you have to adhere to, and bankruptcy would more impact that. So I can't really answer your question right now. I think it's more complicated than that, but I'm happy to chat more later. Yeah.
Thank you very much, Aasthaa. Great talk. I guess I have a general question about like being Canadian, working as a researcher in the US with a healthcare system that's very different than here, and the data collection that is representing this. And then method, like even the definition of financial toxicity might be different. The definitions of disparity might be different. So what are your thoughts with regards to transferring these kind of methods that you've developed and modifying them to fit a universal healthcare system setting and, you know, the slightly different geographical also characteristics? So general thoughts.
Yeah. I mean, that's a good question. I can say a lot about it. I think first of all, like just a lot of our work has focused on race ethnicity. And from what I understand, like, you know, race ethnicity is often not captured. I mean, even in US healthcare data sets, there's issues with capturing race ethnicity accurately. And I've been here 3 weeks, but from what I understand, it's not captured at all in some instances. And I think like variables like English as a second language might be more applicable in terms of like trying to capturing some of the disparities with like the immigrant population and disparities that may be occurring there. I mean, low income and neighborhood deprivation indices that can be captured using census level data could still be captured here as they are in the US. So yeah, I mean, I think there's some initial, and then, you know, the financial toxicity, I understand that there is work being done in financial toxicity here as well, but my naive understanding might just be that maybe I don't know if it's to the same or the effect of financial toxicities or the financial burden is quite as bad here. And this is, again, very naive. I'm Canadian, but I haven't lived in Canada for almost 20 years, so I don't fully understand. But just interacting with, for example, cancer care here for a parent, you know, I see that like we pay nothing, whereas in the US, patients just forego treatment because they can't afford it. So I see those clear differences, and I'm interested in exploring how the same work might translate to Canadian healthcare. But that's just my very high level understanding. So not a great answer, but my initial understanding.
Maybe we'll take one. Let's do those two and then.
Okay.
Let's try not to clear my throat in the microphone. So I was thinking about the first problem you were talking about and in answer to the first question. Are you continuing to sort of update the model as things happen? And there's a follow-up to that depending on that answer.
Yeah, so this was a model that was just developed 2 years ago. If it was implemented in practice, we would absolutely have to update it to, you know, monitor how it performs over time and update using, you know, evolving healthcare practices. And if the disease characteristics of the patients at a given site that's using this model are changing, then we need to adapt it. Right. So currently we have not, we've just developed it and published it, but we would need to update it.
Because you alluded to that, if what happens and they start to skip visits, then they're potentially skipping or delaying treatments. It changes kind of the landscape from where it was built. And so that's always the case with a prediction model that is then used to adjust treatment. It starts to not be very prognostic because things happen in response to it. So at what point do you just determine that, okay, this is no longer a working predictive model, and what do you do to fix it?
Yeah, I mean, so I've, you know, spoken to Lillian Sung and Adam Yan, who are doing work on the, you know, using the EHR data and the predict. I don't think they're here, but there's this idea of silent trials where, like, if you implement a model in practice and you continue to monitor it, and you maybe like randomize patients in practice who are using the model versus not for decision making, and you continue to evaluate how well it's performing. And so that would be a way of evaluating it. And then at what point, I mean, I think it's a little bit subjective, like if it's having a major impact on outcomes, then you would need to say, okay, maybe we need to update this now. And it could be the model, it could, again, it be the changing patient population, it could be changing practices, could be changing treatments. And so evaluating what's causing the model to not perform well, and maybe there's certain populations it would still work well in, and other populations it should not be used in anymore. That would be kind of the ongoing monitoring of the model performance and updating it.
And then we'll need trial methodology. All the way in the back, last question. Yeah.
Thank you. I just have a question on how you evaluate the costs in that decision model. So you were mentioning how you measure the cost in life years versus like the cost of the treatment or the cost of travel or something, and then relating that to the disparities in financial toxicity in racialized groups. Is there a way that you can measure or account for variables in that racialized or disparate groups are going to have higher costs, and therefore in your decision tree will be more likely that that cost is greater than their life and life years, and when to treat and when not to treat? Does that make sense?
Yeah, that's a really good point. Yeah, because you don't, the worst thing you would do is if you then had different thresholds for different patients, it's like, well, for them it's higher cost, so we're just not going to test them. That's not appropriate at all. So far, it's just been like we have looked at life years and just said, okay, if this is going to improve your survival, then it's a good decision to make. As we incorporate costs, we've looked at just incorporating the cost of testing so far, but I have not thought so far as to individual costs or like costs for subgroups and how to incorporate that into decision making. I think that's a loaded question. I think that's a big topic actually of discussion right now. It kind of relates to this idea of like, should you include race, ethnicity, or other variables that represent socioeconomic status when you're developing risk prediction models? Like, there are people who argue for it versus against it, like, because you should you be using different thresholds for decision making to give treatment? There's camps for and against. In some of the work that we've done, we have found that it's better to incorporate the race, ethnicity, and other variables that capture a patient's disadvantaged status, which might then translate to poor outcomes. We should incorporate that into our analyses and decision making. But I've not looked at the specific thing that you're talking about, and that's a really good point and good thing to think about.
Thank you. Great question. It's wonderful to see so many people here, and hopefully a few of you can stick around for a few minutes and join us for dessert and socialize a little bit and introduce yourselves to Aasthaa. So thank you very, very
Thanks,
much.
Aasthaa.